if you had a heart attack or a scan that showed a plaque in your coronary arteries. You maybe even got a stent, and definitely a bag of medications, and follow up in 3 months. What you didn't get is a plan, and nobody sat down to explain what has to happen next so this does not happen again. That's what this video is. I'm Dr. Safa Shiari. I'm dual board certified in internal medicine and obesity medicine. And this is important because preventing your second event isn't one prescription. It's cholesterol, diabetes, blood pressure, weight, and the right doses of the right medications, all managed together. I spent years managing patients in their 60s, 70s, 80s, and 90s, and I've seen what the second heart attack takes from the patient that the first one didn't. And I treat my patients the way I like to be treated. Here's where we're going. 1, your new cholesterol number and how to actually get there. 2, the 2 blood tests that most people never get after receiving this diagnosis. 3, the rest of the protection stack, the medications and the steps the guidelines say you need. 4, beta blockers, medications like metoprolol, carvedilol, and how the research on them has changed and whether you need them or not. So stay for that. Let's start with the number that matters the most. If you had a heart attack or you have a plaque in your arteries, your LDL goal is not just the normal, because normal range is for people who do not have a plaque. The guidelines now say your goal should be below 55, not 100 and not 70 for a lot of people, 55. And why so low? Because that plaque does not negotiate. And every year your LDL runs above goal. The plaque you already have keeps on growing, and new plaque keeps on forming. Below 55 is where the progression slows and the risk of another event drops meaningfully. And how do we get there? First is high-intensity statin. That usually means rosuvastatin 20 to 40 or atorvastatin 40. And here's what most people are never told. Statins does not just lower the LDL number. They also calm the plaque. They will thicken the cap on top of the plaque so it doesn't rupture, and they will calm the inflammation inside it. And a stable plaque is far less likely to rupture, and that rupture causes most of the heart attacks. And that's why we use the statin even in people whose LDL does not look that bad as a number. And then we check your labs 6 weeks later, not next year. And if you're not below 55, or if you're not tolerating that high dose of statin, so then we go back, we try different kinds of it. Any statin will have some benefit. So we might end up with a weaker statin. And if you're already on the max, then we add the ezetimibe. Ezetimibe on its own, it doesn't do much, but with the statin together, it does augment the effect. And after any change, we should check 6 weeks later. And if you're still not at goal, we can add a PCSK9 inhibitor. It's typically an injectable medication, and recently a pill form has been approved, but we haven't seen it prescribed yet. The guidelines are clear. We got to keep optimizing until you're at goal. Now, the 2 tests that should be on your chart, and probably are not. First is ApoB, the protein that carries the cholesterol through your bloodstream. And it accounts for the actual particles that enter your artery wall, which makes it more accurate measure than just checking LDL. So for example, when your triglycerides are high, which is a different type of lipid in your blood, when they're higher, they will make your LDL measurement look falsely lower than what it is. So we might think we achieved the goal, but we didn't. And in this instance, the ApoB is more accurate. The second test is lipoprotein A. It's a genetically inherited cholesterol particle, significantly raises risk for heart attacks and strokes, and it isn't routinely tested. Luckily, the 2026 guidelines have started recommending that every adult should get checked for this at least once. If you've already had an event, knowing your LPA matters even more, because a higher level means a remaining higher risk than other people, and we need to treat your risk factors aggressively. Neither of these tests is exotic. Both are simple blood draws. They do not require fasting. Most people who've had a heart attacks haven't had those tested. The guidelines do not stop at cholesterol. Here's the rest of the stack. Antiplatelets are medication that will stop the platelets from clumping up on that ruptured plaque and blocking the artery. So people who have evidence of a plaque will require one antiplatelet forever. And that's typically aspirin or clopidogrel, also known as Plavix. But after a stent, you're usually on aspirin and a second antiplatelet for a period of time, and then on aspirin alone. The exact duration is individualized. The rule that is not individualized is never stop these medications on your own, because stopping early is how these stents could clot. And a clotted stent is another heart attack happening so fast. You'll need an ACE inhibitor or ARBs. if your heart pumping function is reduced because of that blockage, or if you have high blood pressure, diabetes, or kidney disease. Also, if that pumping function is reduced, you will need a beta blocker. So these are metoprolol, carvedilol, or bisoprolol. There are other beta blockers, but they have not shown to carry the same benefit. And you might also need a mineralocorticoid receptor antagonist like spironolactone or a pleurinone. And then if you have diabetes, SGLT2 inhibitor medications can help with that and with the reduced cardiac pumping function. And now if you have diabetes or elevated weight, GLP-1 medications like semaglutide, Ozempic/Wegovy reduce repeat cardiovascular events in people with heart disease and elevated weight, even without diabetes. If nobody have discussed these with you, that's a conversation worth having. We still don't have the studies for all types of GLP-1 to show this benefit, so it has to be a balance between what your insurance covers, which strength of these medications we need to control the diabetes or lose the weight, in addition to the heart protection. Cardiac rehab. This is a class 1 recommendation. It cuts mortality, and roughly half of eligible patients never go. So if you weren't already referred, ask to be, which is doing rehabilitation, so having you exert yourself while you are under observation for your heart rate, for your blood pressure, to know how to challenge your body safely to get you back to your normal activity. And now the unglamorous ones, we gotta keep your blood pressure under control, so below 130 for the top number and below 80 for the lower number. And if you smoke cigarettes, quitting is worth more than everything else in this video combined. Now the part I told you to stay for. Everyone who had a heart attack went home on a beta blocker. Everyone. That era has ended. Large trials published in the last 2 years looked at patients with heart attacks whose heart pumping function stayed normal. And they found that routine use of beta blockers did not reduce death or repeat heart attacks in that group. And this is the part that matters. If your heart pumping function dropped, that's if your ejection fraction is reduced, beta blockers still carry a real proven benefit. This is bittersweet for me. I've had patients dragging themselves through dizziness, fatigue, shortness of breath for years on a beta blocker that they might have not needed. And I've had patients with weakened hearts for whom this medication is genuinely protective. So the first question is, what's your ejection fraction at the time of the heart event? It's on your echo report, and if you don't know, you gotta find out. If you do need a beta blocker, then the details matter. The agents we mostly use with evidence behind them are metoprolol, succinate, and carvedilol. So if you're on a different beta blocker, I would think atenolol, propranolol, usually started for something else like high blood pressure or anxiety. You need to ask to have them changed. And the dose matters. The protection was shown at target doses. So increase gradually and watch out for side effects like a low heart rate, fatigue, shortness of breath, until we reach the target or the maximum dose that you can tolerate. So the prescription is not a protection until it's at the right dose. And typically with these medications, we don't stop them suddenly. We stop them gradually like we started them for any reason if we need to. So if you need to make any change, make sure you make it gradually with your physician. Screenshot these two lists, what you can do starting today and what to ask from your doctor. So what you can do, find two numbers, your LDL and your ejection fraction. Look them up on your records in the portal, discharge papers, or call the office. 2, take every medication as prescribed. Never stop them, especially beta blocker and antiplatelet on your own. Say yes to cardiac rehab, and if you weren't referred, ask if you qualify. 4th, try to walk daily and build from there. 5, eat Mediterranean style. Focus on vegetables, fish, olive oil instead of butter, nuts, and less processed food. If you smoke, make it quitting the project. A yearly flu shot has shown to reduce cardiac events. Now, what to ask your doctor in a priority order, because most visits are getting shorter, and the patient who walks in with written priorities gets more out of these visits. First, is my LDL below 55? And if not, are we changing or adding new medication? And when are we going to check it? Remember, we need to check that after 6 weeks from making the change. Second question is, have I had ApoB or lipoprotein A checked? Third, what is my ejection fraction? And based on it, do I need a beta blocker? And if so, what is the right one, the right dose, and what is our plan to titrate it up? 4th, what is my antiplatelet plan and for how long? 5, please refer me to cardiac rehab. Here's the problem. The months right after heart attack is the titration window. Your LDL should be checked after 6 weeks from starting statin. Beta blockers should be increased every couple of weeks, depending on what you're tolerating and your symptoms. And if you're having any side effects, we have to come up with a backup plan. But in most of the clinics, you get an appointment the week right after you leave to start these medications, and then your second appointment rarely comes before 3 or 6 months. Those changes simply don't happen. And you'll be lucky if you get to see your actual cardiologist, heart doctor, or your primary care doctor during these visits, and not someone else covering who doesn't know where things started and where we're heading. The protection exists on paper and never reaches you. The more frequent we measure, adjust, and work around side effects, the faster you get to full protection. This is how I built this practice. I work alongside your cardiologist, not instead of them, and I see patients as often as weekly or every 2 to 4 weeks while we're actively working on this. And the first visit is a full 60 minutes, and we go through every medication, every target, and every gap. If you do nothing else today, find out your LDL and ejection fraction. Those two numbers decide most of what you just heard. And if you want a physician who runs this plan with you between cardiology visits, I see patients in Wisconsin and Massachusetts by telemedicine. Everything is in the link below. Remember, everything in this video is educational and is not medical advice. You walked out with a stent and a bag of medications, and now you know the plan.